Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
My name is Slaven Bajic. I'm an emergency medicine doctor from Slovenia. For those who don't know, it's a small country between Italy and Austria, small Alpine country. And I work in this hospital on the Adriatic Sea. So I work in the ER and I work pre-hospital. I'm also focus ultrasound instructor for Quorum, for Wim Focus and use. Bad thing for business for every emergency doctor in Slovenia is that Slovenia is one of the 10 most peaceful countries in the world. So except traffic trauma or injuries on skiing, we don't see a lot of violence. So that's the problem. But I was fortunate enough to be a chief of the ER in the Role 2E hospital in Mali, where I saw a few things. So how many of you haven't used ultrasound before? So most of you did it. So ultrasound was when it started, was focus ultrasound like revolution in emergency medicine. Now really I use it more than my stethoscope. Also hospital or pre-hospital, definitely more time than stethoscope. Things that we can see with ultrasound in POCUS exam are this. So fast protocol that we will talk today about it, rush protocol, lung exam, cardiac exam. We can check the big vessels, aorta, vena cava. We can check the Doppler of the legs. We can check abdominal emergencies, and we can do the nerve blocks on the field. So today we're going to talk about FAST or focus assessment sonography in trauma. I will skip the next one because most of you did already ultrasound exams. So what's the purpose of the FAST exam? To assessment of abdominal and thoracic cavity for a free fluid. Most of the time it's blood. So to check for internal bleeding. When we do the FAST exam, we do the FAST exam with all patients with penetrant and blunt abdominal trauma and with penetrant and blunt thoracic trauma and with patients with undifferentiated shock. So FAST exam and other ultrasound rush exam, they can help us a lot to define in what kind of shock is patient. It can lead us quickly. In 1-2 minutes, it can lead us to the cause of the shock. First, we want to explain how to do FAST quickly and all e-FAST in all 5 points. And then I'm going to talk about advantages of FAST in Austere settings and per-hospital settings. So basic FAST exam has 4 parts. And extended FAST, we check also the lungs with the abdominal exam. We start with a Morrison's pocket, so it's the right upper quadrant of abdomen, and we check presence of the free fluid or internal bleeding between liver and kidney. So we put a probe in the bottom of the ribs, in the anterior axillar line or medial axillar line, and you will have that picture when you put your probe there. So how it looks when FAST is positive. Looks like this. So fluid or blood is anehogenic or black. So if you see the black stripe, okay, it's not always big like this. It can be small, very small. But if you see the black stripe of the fluid between liver and the right kidney, FAST is positive. Then we go to the next area. So next area is left upper quadrant. So it's splenorenal space. It's space between spleen and the left kidney. It's similar. You will have a similar picture like in the Morrison's pouch. You will see the kidney. I don't know, is this working where I exchange the batteries, but okay, I can't now. So between them, this line, it's obviously that we don't have a free fluid now, but if it would be pathological, you will have something like this. So this is presence of the free fluid in splenorenal space. Then we go to the next. It's pouch of Douglas. It's ideal when we see it in women, of course, because it's the space between uterus and rectum. In men, equivalent is rectovesical pouch between rectum and bladder. And presence of the free fluid we can see like this. As I said, it's anehogenic and it's black. The fourth one is pericardial space. So we put a probe, subxiphoid. So you anatomically find a bottom of the sternum and you put a probe. Those who have been here in Friday when we had the workshops, you could see how to do it. Heart is a little more complicated than other ultrasound exams, but we saw it. You put a probe there and you see that. So you see the liver, you see the heart, and pericard between them. Obviously here, of course, is that we don't have a free fluid. How it looks like when we have it. It looks like this. So this is my video. One patient they brought to my ER. It was suspect pulmonary embolism because he was heavy breathing. Actually, he had the cardiac tamponade. So it's like this. You see the heart. You see the free fluid around the heart. It was subxiphoid projection. So you see the right ventricular collapse. It's typical cardiac tamponade. And at the end, we have fifth thing for extended e-FAST to check for pneumothorax. So you saw already that also in Friday. You put your probe. Is it working now? Yes. Good.
Pointed towards that one.
Left, right, and the right. Good. Great. So you also have saw it in Friday on our workshops. You put your probe in the second or third intercostal space here, longitudinally, and you will see this picture. So you will see this ribs and pleural line. And as we show you on Friday, or as the people that they already do ultrasound knows, if the pleural line is moving, we don't have pneumothorax. We can also use mode to help us. So those are the 5 basic exams for the eFast that we can check for the presence of the free fluid or pneumothorax. So now I'm going to talk, after this, I'm going to talk about advantages of the FAST protocol in pre-hospital settings in the field. So what are the advantages? Systematic assessment of key areas, as I told now. So key areas of abdomen and thorax. Okay. Then here's another thing. FAST is rapid and repeatable. So skilled person who do ultrasound all the time, focus ultrasound, he can do a FAST exam under 1 minute. It's very quickly. When you used to do it, you just go scan all 4 points and 5 eFast literally in 1 minute. And in 1 minute, you can exclude some real pathological things. Then FAST is repeatable. It should be repeatable. Not should, it must be repeatable. So you must repeat FAST exam, because when you check the patient in this moment, if FAST is negative, it doesn't mean that it will be negative in, 5, 10, 20 minutes. So you must repeat it. FAST is dynamic exam. If you are observing your patient in ER, or if you have prolonged field care, long transport, I advise that you check FAST all the time if something's happening. If you write a report, always write on your report, FAST exam is negative in the moment of the exam, to protect yourself, because we don't know, will it be negative in 5 minutes. So you must repeat it. Okay, it's non-invasive. As we know, ultrasound is not invasive it's not... I forgot the English word now. Not like the X-ray and CT, doesn't radiate the patient. It has high sensitivity for free fluid. We can check even 200 milliliters of free fluid with a FAST. And it guides us to immediate decision-making on the field, also in the ER, but now I'm talking about the field. Okay? So how it guides us? So if we have patient hemodynamically unstable, shock with a positive eFast, probably he needs emergency surgery or damage control resuscitation. Probably he will be first candidate for the MEDVAC. If we have a negative FAST, but still unstable patient, he needs further exams. As I said, another FAST exams, or he needs further diagnostics like a CT when we transport him. And FAST can lead us to other procedures. So if we have a positive pericardial effusion, we can do pericardial synthesis. If we have a pneumothorax on the eFast, we can do decompression. So it leads us to other methods. So benefits of the FAST in combat and austere environments. First thing, as I said before in the previous one, rapid identification of unstable patients. So if we have multiple casualties on the field with FAST exam, we can quickly decide who of them they need a quick transport, they need quick surgical intervention, who is priority for the MEDVAC. It helps prioritize MEDVAC, so to see that, to not use it, to spare it for the real emergencies. Another one, so as I said, it's non-invasive and portable. So you can carry your ultrasound in your bag. You can carry in your rucksack, in your medical kit, because it's very small. Probably worked with Butterfly, you worked with Vscan. So it's very small. You just need your mobile phone, your Butterfly, and you carry it with yourself. Another one is particularly useful on the field. It's performing without disrupting tactical position. So you can perform it everywhere, literally on the place of the injury. You don't need to move patient. And of course, the word I was searching before, English is not my primary language, no radiation exposure, like with the X-ray and with the CT. Next thing, early detection of internal bleeding. As we said, after we do complete FAST exam and the eFAST exam, we can exclude hematoperitoneum, hemothorax, cardiac tamponade, pneumothorax, and we can differentiate the shock, kinds of shock that our patient has very quickly. And it can guide us, of course, to the other specific procedures, as I talked before. At the end, it reduces unnecessary evacuations and interventions. So if we have stable casualty with a negative FAST, then we can use our capacities for evacuation for other more emergent patients. And of course, prevents unnecessary surgical exploration. There are also some limitations about using the ultrasound and using FAST exam in the austere environments. So first one is operator dependent. So everybody needs to learn how to do it. This was like when we had a Mali, like a workshop for other doctors to use the FAST in the field. Of course, everybody can make mistakes when you're doing exams. Also, the most skilled persons, they can make mistakes. Another one, limitation. The next one. So limited sensitivity in early bleeding. As I said, we can check from 200 milliliters up, but early bleedings, we can't. We can see retroperitoneal bleedings also with the FAST. It's impossible. And it doesn't differentiate from other fluids. like from ascites, like, I don't know, urine. Also, women in ovulation, they can have a little of free fluid down there in the Douglas pouch. So fast doesn't tell us it's most of the times it is blood. So what is the solution? As I said before, do serial fast exams. Do them all the time during the transport or observation. And of course, clinical judgment. So always we must compare it with the clinical status of patient. Next one, environment challenges. So what can happen in Austere settings? A limited battery life. If you don't have spare batteries, or for your ultrasound, or for your telephone, or if you don't have electricity power source, that can be a problem. In cold environments, it can also limit the life of the battery. And sand, dust, and other environmental misfortunes can also impact negatively on your probe. So they can, limited diagnostic capability. As I said before, it doesn't differentiate the blood with other fluids. Also, doesn't assess retroperitoneal bleeding. It doesn't assess internal organ injuries. It doesn't help us with the head injuries, with the extremity injuries. So those are the limits of the fast exam. Patient positioning is the next thing. So, of course, when we have ultrasound workshops, if everything is ideal, we always have supine patient. We work on it. But patient will not always be supine in the Austere settings. It's easy to do the fast exam on the supine patient. But if you have lateral position, if sitting position, if you have a confined spaces, very short space in helicopter, in ambulance vehicles, sometimes it's very hard to do it. So if patient is slightly inclined, you scan the right upper quadrant first. You can have anterior approach. So if he's little inclined, do not do it here. Make anterior approach to the kidney and the liver. If he's sitting, first check the Douglas pouch. And in all kinds of transport, when we don't have ideal position of the patient, the most three important windows of the eFast where you can detect life-threatening injuries are Morrison space, the upper quadrant, cardiac space, and the lungs for pneumothorax. So if you're limited with, space, with time, with position of the patient, first check all those three spaces, Morrison pouch, pericard, and the lungs. Another thing that can bother us on a field, so field conditions. I talked about cold weather before. It can impact our battery life. Darkness, dust, everything can impair our visibility on the ultrasound. What can we do? Solutions for that. So first thing you can do, of course, increase screen brightness, the gain, the depthness, contrast. Night vision goggles can't help you with that because they work on infrared and low visibility, so they can't work with the blue light from the screen. Use a headlamp, use a small LED lamp, anything that can help you. Cover the probe to protect it from the dust. If you have freezed your gel, what can you do? You can warm it with the IV fluids, so with the ringer lactate, with the saline. If we don't have gel, if we are stayed out of gel on the Austere settings, what can we use? We can use water, we can use saline, we can use liquid soap, hand sanitizer, even you can use the blood, because blood coagulates, doesn't have a lot to be like other things. But if you don't have anything else, you can dip it in the blood and use it for first help. Probably with visibility, it would not be perfect like with the gel, but you can use it. So it's first help on the field. Okay, so those are the benefits and limitations of the fast protocol on the field. And for the end, I have one case report from Mali that to show you how the fast helps quick decisions treating injured patients. So we worked mostly in the ER, but sometimes they deployed us also, doctors on the ER on the field. And in one situation, it was in northern Mali, in Timbuktu, when explosion hit the 3 soldiers. We had the 3 injured. So ambulance arrived, and our patient, I don't have pictures of that, of course, but our patient, he was 27 years old, soldier. He was injured with a blast injury and with a penetrate abdominal and thoracic injuries. Primary survey, we checked vitals. As you saw, patient was in shock, 120 heart rate, 90-60 blood pressure, shallow breathing, dyspnoic. Obviously, that patient was in one kind of shock. Suspected injuries were, of course, internal hemorrhage, pneumothorax. So after the primary survey, we did a fast exam. What would have been so on a fast exam? So in pericardium, it was small, just a small fluid, but not a tamponade. You must differentiate tamponade and just small present of pericardial effusion. As you saw on my video, in tamponade, the right ventricle is collapsing. It's not. So in Morrison pouch, it was positive for the free fluid. In the splenorenal pouch, it was positive for free fluid. Douglas space was free. And transient pneumothorax was suspected because we didn't have a lung sliding on the left side of the thorax. What have we done with that patient? So we had we saw with the FAST that is a patient probably with internal hemorrhage and with pneumothorax. Okay. We did, of course, needle decompression for pneumothorax, 15 liters of oxygen, permissive hypotension strategy. He got 1 liter of saline. We did the tranexamic acid and analgesia with ketamine. Evacuation plan was that he was priority for medevac. We called in the roll 2E and informed the surgeons that patient probably has internal bleeding. And it was 15-minute flight to the nearest roll 2E. Patient was talking directly to the OR. It was a laceration of the liver. It was ruptured spleen, and he has a pneumothorax, as we said before. So fast ultrasound spared us a lot of time, guided us to other life-saving interventions like pneumothorax decompression, like permissive hypotension, to give patient tranexamic acid, and confirmed the need for medevac evacuation. So, for the conclusion, generally, focus ultrasound and, of course, EFAST protocol are very useful in emergency and Austere settings. This is the ambulance car that we had there in Kulikuro. But, of course, this one is most important. As I said before, FAST cannot replace clinical judgment. So always compare it with your clinical status of patient. Negative FAST does not rule life-threatening injury, does not rule out need for emergency surgery. So have your common mind with you and compare always status of the patient with your ultrasound exam. That's the most important things. And as I said at the beginning of the lecture, ultrasound is not future, it's present of emergency medicine. I think now it's impossible to do emergency medicine, even in the ER, even pre-hospital, without using emergency ultrasound. And we have a good courses of emergency ultrasound in college. Our APOS course, I know some of you that you have been there, so welcome, join our courses, and that's it for me. Thank you. Are there any questions?
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.